Let's move on to the second lecture today. Let me introduce Dr. Saud Al-Haidi, one of the consultant hematologists and stem cell transplantation and cellular therapy department in King Faisal Specialist Hospital and Research Center. He'll be introducing his guest today. This is a satellite talk sponsored by Janssen. So Saud, are you online? Okay.
Oh, yes. Yes. Assalamu alaikum. Can you hear me now?
Yes, I can.
Okay. So it's my honor to introduce Dr. Maria Mateos. She is an associated professor of medicine at University of Salamanca, Spain, and also she's a director of myeloma program and a coordinator, a clinical trial unit in Salamanca University in Spain. As you know, Dr. Mateos is member of an international myeloma working group, International Myeloma Society, and also EHA. In addition, she is an editor of many myeloma, editor in many journals, including Annals of Hematology, New England Journals of Medicine, and Lancet of Hematology. Dr. Mateos has more than 140 papers in peer review, international journal, and it's my pleasure to introduce her. Our talk today gonna be current treatment options for transplant eligible in a newly diagnosed multiple myeloma. Without further delay, Dr. Mateos.
Okay, so thank you very much. And honestly, I can expand my screen. Yeah, now, and I am going to try to move through the slides. That I think that it is not possible for me.
Sir, just double click on the screen.
So thanks for the kind introduction, and first of all, thanks for the invitation to this important meeting. And in fact, I had the opportunity to be in Saudi Arabia a couple of years ago, and my experience was great. So hope all of you stay safe, and thanks to Janssen for the organization of this satellite symposium. And I will talk about the management of newly diagnosed myeloma patients, and my talk will be concentrated on the transplant eligible patients. Here you can see my conflict of interest, and I would like to start my presentation speaking or discussing a bit about the potential treatment goals for newly diagnosed patients with multiple myeloma. And the cure maybe is not a completely realistic possibility, although I think that with the new advances and the new options of therapy, we are going to be able maybe to cure some patients with multiple myeloma. But in principle, we have to try to prolong definitely the overall survival, to delay the progression-free survival, and of course, to try to maintain the quality of life of our patients. And today we know that the depth of the response is something relevant, and the maximal eradication of the tumor clone is going to be associated with a better outcome. And this is one of the main objectives we have to plan when we have a newly diagnosed myeloma patients in front of us. This is the role of the conventional complete response, the serological complete response that has been a typical endpoint. And when our patients with myeloma achieved serological complete response, the outcome was better, as you can see here in this slide. But in 2021, definitely we have to move forward the evaluation of the measurable residual disease, because this is, I would say, the new complete response. And here you can see how in a clinical trial conducted by the Spanish myeloma group, in this population, transplant eligible, newly diagnosed myeloma patient receiving induction with RVD, followed by transplant, consolidation, and maintenance, the minimal residual disease evaluation, in this case by next generation flow before maintenance, established two different subgroups of patients. And you can see here how the group of patients achieving minimal residual disease negative presented a significantly better outcome in comparison with those in which the minimal residual disease was positive. And this has been confirmed in another large trial conducted in this case by the French group together with the Dana-Farber Cancer Institute, also in a large series of patients, including RDD followed or not by autologous stem cell transplantation, utilizing next-generation sequencing, sensitivity level 10⁻⁶, and patients achieving undetectable measurable residual disease had a significantly longer progression-free survival. And today, in 2021, we have to incorporate also the imaging assessments into the evaluation of the response, because the concept of a complete metabolic response has been also incorporated. And this is a presentation from US 2020, in which newly diagnosed myeloma patients included in a clinical trial conducted in Italy put in context how patients achieving complete metabolic response presented a longer progression-free survival, as well as also longer overall survival. And when they decided to combine both complete metabolic response with minimal residual disease negativity, in this case by flow cytometry into the bone marrow, a specific subgroup of patients was identified with definitely an excellent outcome. So in the future, I think that this is going to be our main objectives when we have newly diagnosed myeloma patients transplant eligible in front of us. However, it's true that if you remember the progression-free survival and the overall survival curves I have just showed you, some patients, in spite of the minimal residual disease negative, they finally relapse. And there are two important points, two important concepts in which we are investigating in order to optimize the measurable residual disease evaluation. The point number one is the sensitivity threshold, because the International Myeloma Working Group guidelines recommend at least sensitivity of 10⁻⁵, but we know in this meta-analysis published in Blood Cancer Journal in 2020, when patients achieved sensitivity level of 10⁻⁶, less patients are going to be identified as minimal residual disease negative, but the hazard ratio for progression-free survival is lower, indicating that its value is much more strong. And the same concept is applicable to the sustained MRD negativity. It is so important as to achieve MRD negativity as to maintain it over time. And again, in this meta-analysis, you can see here how patients starting maintenance and maintaining the MRD negative 1 year after starting maintenance resulted in a hazard ratio for progression-free survival lower in comparison with the intent to treat patient population. So these two important points are going to help us to identify definitely the minimal residual disease negativity as an important, if not the most important prognostic factor predicting progression-free survival and overall survival. And the International Myeloma Working Group recognized in 2016 this new response criteria. My recommendation would be to utilize them if the technology is available, because definitely today MRD negativity is an important prognostic marker, and in the near future we will start to incorporate this MRD status in order to establish modifications in the therapy. If we focus on the management of the patients with a newly diagnosed myeloma patient, and we consider that our patient is transplant eligible, in 2021, definitely the chronological age should not be anymore the only factor driving our choice, and we have to incorporate the biological age together with the comorbidities, disabilities, even patients' preferences, in order to distinguish between transplant eligible and transplant ineligible. If our patient is definitely transplant eligible, maybe you agree with me that if we go to the European guidelines or the NCCN guidelines or whatever local, regional, or national guideline, the management usually includes induction, followed by autologous stem cell transplantation, consolidation, yes or not, and maintenance therapy. If we focus on the induction, it's true that today the standard of care are at least 3 drug-based combinations, VTD, BCD, VRD, or a new standard of care has recently emerged, and it has been recently approved by the authorities in Europe as well as in the US and in other countries, and it is based on VTD plus the monoclonal antibody anti-CD38 daratumumab. But when we go to the European guidelines recently published in EMA-FAIR and in Annals of Oncology, you can see here how these combinations, the first option is VRD, Dara VTD, VTD or BCD as second options if the first ones are not available, followed by transplant and maintenance with lenalidomide. We have to put in context these possibilities, and VTD has been a standard of care we have utilized commonly in Europe. And here you can see the experience coming from the Italian and the Spanish myeloma groups with a couple of clinical trials conducted many years ago. And in fact, what I would like to put in context here today is the longer follow-up for these two studies. Median follow-up of approximately 10 years, and you can see here how VTD resulted in a median progression-free survival of approximately 5 years, and important from the overall survival point of view, at 10 years, between 50 and 60% of the patients remain alive. So VTD has been an optimal standard of care we've been utilizing during many years as induction for this population. CyBorD would be another possibility. From my point of view, it's suboptimal because it has been compared with PAD or even with VTD, and it's inferior in terms of response rate as well as overall response rate. But if there is not any other possibility, of course, CyBorD is also a feasible and a possible induction regime. And VRD is another quite common standard of care. Definitely in US is the most common regime utilized as part of the induction before autologous stem cell transplantation. And I have to say that in Europe, in spite of our authorities did not approve RVD for induction before autologous stem cell transplantation, in many countries it has been also the standard of care. And one of the reasons is the French study or this Spanish study in which we included almost 500 newly diagnosed myeloma patients transplant eligible, and we utilized VRD as part of the induction and as part of the consolidation after autologous stem cell transplantation. And we did a retrospective comparison with VTD, and VRD was a bit better in terms of response rate before and after autologous stem cell transplantation. But the main advantage is the toxicity profile, because as you know, lenalidomide does not induce the peripheral neuropathy. But the new standard of care, as I previously told you, is VTD plus daratumumab evaluated in the Cassiopeia study. This phase 3 randomized study included over 1,000 patients in 3 European countries, and VTD 4 induction cycles, transplant, and VTD 2 cycles consolidation was the control arm. And in the experimental arm, daratumumab was added as part of the induction and as part of the consolidation. The primary endpoint of this study was stringent complete response after consolidation. And here you can see how response rate improved over time. And at the moment of the last follow-up, 54% of the patients receiving Dara plus VTD achieved a complete response, significantly higher in comparison with the 38% of complete response reported with VTD transplant and VTD as consolidation. I previously alluded to the role of minimal residual disease as an important endpoint, and in fact, in this study, approximately 60% of the patients achieved MRD negativity, utilizing either flow cytometry or next generation sequencing. And you can see here how after consolidation, VTD resulted in 37-40% of minimal residual disease negative. So definitely the addition of daratumumab improved and upgraded also the quality of the response. And the probability of achieving MRD negativity with the DARA VTD was sustained across the different subgroup of patients. And I decided to remark here patients with ISS3 and patients with high-risk cytogenetic abnormalities, because you have to know how important is patients with high risk achieve MRD negativity, because this achievement is going to be able to overcome the poor prognosis of the presence of high-risk cytogenetic abnormalities. The deepest the response, the better the progression-free survival. And here you can see how when patients achieve MRD negative by flow cytometry or next-generation sequencing, the outcome is much more better. And in fact, the progression-free survival for these patients is excellent, although it's true that the follow-up is of approximately 1.5 years. This is the progression-free survival from the first randomization. This is not the primary endpoint. The follow-up is 1.5 years, but there is a significant benefit for the addition of daratumumab as part of the induction, as part of the consolidation, and maybe also as part of the maintenance, as we are going to see later on. And the hazard ratio for progression-free survival is 0.47, but the magnitude of the benefit and the difference is evident and will be even better with longer follow-up. The benefit or the superiority in terms of progression-free survival, again, is sustained across the different subgroup of patients, including those patients with ISS3, as well as patients with high-risk cytogenetic abnormalities. And this is the overall survival that is immature yet because the very short follow-up, but the curves started to separate in spite of the short follow-up, and definitely we have to wait how this data evolve over time. In terms of safety profile, we can't forget that we were dealing with young, newly diagnosed myeloma patients, and really the addition of daratumumab as part of the induction and as part of the consolidation resulted in no more hematological or non-hematological adverse events, a slightly higher frequency of neutropenia grade 3-4, as well as thrombocytopenia, no more peripheral neuropathy, no more gastrointestinal toxicity. And in fact, when we evaluate other common adverse events that we usually see when we treat our patients with the daratumumab, like infections, you can see here how in the Cassiopeia study, the rate of infections was comparable. Infusion-related reactions is the only adverse event specifically allocated in the DARA arm, but it is observed in 35% of the patients, only 4% grade 3-4, and you have to know that with the subcutaneous formulation, these infusion-related reactions decreased and will decrease in a significant manner. What is the impact of daratumumab in the peripheral blood stem cell collection? In principle, there is not any problem. You can see here how patients were able to collect 6 million of CD34 cells and almost 9 million in VTD. So CD34 cells enough in order to do 1, 2, or even 3 autologous stem cell transplantation. And in fact, the proportion of patients who finally received the autologous stem cell transplantation was over 90% in both arms. This data supported clearly the approval of VTD plus daratumumab as a new standard of care in this population, approved by FDA, European Medicines Agency, many other authorities, and as I previously told you, the European guidelines recognized DARA VTD as a standard of care. What about the quality of life? I told you at the beginning that within the main objectives we can plan for this population, in addition to prolong the overall survival and the progression-free survival, we have to try to maintain the quality of life of our patients. And in the Cassiopeia study, overall, this is the global health status score reported by patients. And you can see how this global health status reported by patient was slightly better for DARA VTD versus VTD. But when some specific domains were evaluated, like the cognitive function as well as the emotional function, you can see how this difference is statistically significant post-consolidation. And the same is applicable to an important domain that is the pain, something that clearly impacted the quality of life with the patients, and patients improved pain, significantly improved post-induction, but this benefit was much more evident at the end of consolidation. In addition, just one additional comment, you know that the diagnostic criteria for myeloma updated in 2014, and it is possible now to do the diagnosis of multiple myeloma to patients without any CRAB symptomatology. This is the subgroup of patients included here with SLIM criteria. So just with any one or more of the biomarkers, you know, more than 60% of plasma cell bone marrow infiltration, serum free light chain ratio higher than 100, or more than one focal lesion in MRI. And in the Cassiopeia study, they separated this subgroup of patients included just with SLIM criteria without CRAB symptomatology. And overall, in SLIM only and in patients with CRAB, DVTD was always superior to VTD. But when we compare the DVTD SLIM only and DVTD CRAB criteria, it seems that the complete response rate as well as the probability of achieving MRD negativity was higher for these patients included without any CRAB symptomatology, and the benefit in terms of progression-free survival is not observed yet in a clear way, definitely because of the short follow-up, but it would be interesting to see if the outcome for this patient would be even better, and this would put in context how the early detection and the early intervention finally will result in a benefit even in terms of outcome. Just before finishing my presentation, let me discuss with you some important issues that have been addressed at ASH 2020. And one of them is if it is possible to serve autologous stem cell transplantation at relapse, because sometimes we have to consider the patient preferences, or we have to consider the risk status, or even the minimal residual disease evaluation. But the data we have today are coming, point number one, from this French study in which 750 newly diagnosed myeloma patients were included, receiving 3 induction cycles with RVD, followed or not by autologous stem cell transplantation. So transplant was compared with consolidation with 5 cycles of RVD, and all patients received maintenance with lenalidomide for 1 year. And probably you know how transplant was superior in terms of progression-free survival, and this was the primary endpoint, but after a very long follow-up, approximately 90 months, no significant benefits were observed in terms of overall survival. Important point to consider, approximately 90% of the patients who did not receive a transplant in the upfront setting, they received it at the moment of the relapse, and maybe this can explain the lack of difference in terms of overall survival. We have another clinical study conducted by the European Myeloma Network, and including also over 1,000 newly diagnosed myeloma patients. And again, transplant was compared, in this case, with consolidation with bortezomib, melphalan, and prednisone after induction with Cy/Bor-D. And when the role of transplant was evaluated here, and after also a longer follow-up, transplant was superior in terms of progression-free survival, but also translated into a significant benefit in terms of overall survival. What are the main differences? You had the opportunity to see in the previous slide how the comparator was not RVD, but a VMP, and the induction regime was Cy/Bor-D. And I previously told you how I consider that Cy/Bor-D is maybe suboptimal. But there is another important difference, that in this study, only approximately 1/3 of patients in the VMP arm received the transplant at the moment of the relapse. And this can explain, at least from my point of view, this benefit in overall survival, and especially the lack of benefit in overall survival reported in the French study. And there is one additional study conducted by the Italian myeloma group, the Forte study, evaluating KRD transplant and KRD as consolidation with a KCD transplant, KCD consolidation, and KRD 12 cycles without autologous stem cell transplantation. And when the progression-free survival was evaluated, you can see how the winner was KRD, followed by autologous stem cell transplantation. And in the middle, you can see here KRD 12 cycles. And again, in the left part of the slide, you can see how the minimal residual disease negativity rate was significantly higher for patients receiving KRD transplant and KRD as consolidation. In order to try to answer to this question, is it possible to reserve autologous stem cell transplantation at relapse? I would say that today continues being standard of care, and I think that is a complementary strategy rather than alternative to all these novel agents-based combinations, even incorporating the monoclonal antibodies anti-CD38. It's true that the absence of benefit in overall survival makes possible to consider sometimes the patient's preferences, but I think that the next question to be evaluated in prospective clinical trials is not early versus late transplant, but maybe transplant yes or not in some patients. Would it be possible to skip a transplant in some patients? From my personal point of view, maybe standard risk patients receiving optimal induction, 3 drug-based combination plus monoclonal antibodies and achieving MRD negativity could potentially skip autologous stem cell transplantation. Next question is about the role of consolidation. And I previously alluded to this, and in fact, in the recommendations, induction, transplant, and maintenance is always observed, but consolidation, we can put a question mark. The European Myeloma Network addressed also the role of consolidation in the same clinical trial in which transplant has just been evaluated, because patients were randomized again to receive consolidation with RVD versus no consolidation. Definitely consolidation with RVD improved the quality of the response and translated into a significant benefit in terms of progression-free survival in both arms, VMP or autologous stem cell transplantation. However, I would like to pay your attention to the forest plot you can see in the right part of the slides, because when we evaluated the benefit in patients achieving stringent complete response or complete response after transplant or VMP, and definitely before consolidation, you can see here how the benefit for BRD is not so evident and in fact crosses the number 1. What is my conclusion coming from this analysis? That together with the stamina trial, in which you probably know that no significant benefit was observed for consolidation with RVD versus second consolidation with a second autologous stem cell transplantation versus no consolidation, maybe from my personal point of view, is that if after transplant you consider that you are going to be able to upgrade the quality of the response, go to consolidation. If you consider that your patient has achieved the optimal response, maybe minimal residual disease negative, I would directly go to maintenance and I will not give consolidation to my patients. Around the concept of tandem autologous stem cell transplantation, you probably know that patients with high-risk cytogenetic abnormalities usually benefit from tandem autologous stem cell transplantation, although it's true that this concept has not been evaluated in the situation of 3 drug-based combination plus monoclonal antibodies anti-CD38. And the evidence is coming again from the European Myeloma Network trial, in which you can see here how patients receiving tandem autologous stem cell transplantation experienced the same progression-free survival regardless of the cytogenetic information. How are we going to improve all these results? Definitely, we are going to improve the induction, carfilzomib, lenalidomide, and dexamethasone, evaluated in the Forte study. But definitely, I think that we are going to move to 3 drug-based combination plus monoclonal antibodies. VTD plus daratumumab is today a standard of care, but personally, I consider that RVD plus daratumumab, RVD plus isatuximab will be maybe the new standard of care for these transplant-eligible newly diagnosed myeloma patients. We will see if we will continue doing transplant to all patients, and novel options about maintenance are going to be incorporated. In terms of induction with DARA plus VRD, the Griffin study evaluated this new combination. This is just a phase 2 randomized study, and the addition of daratumumab to VRD significantly increased the complete response rate as well as the minimal residual disease negativity rate. And this was the primary endpoint. So the trial met its primary endpoint. No benefit has been so far reported in terms of outcome, PFS or overall survival, but definitely we have to consider that the sample size was rather small, and we have maybe to wait to have the results of the phase 3 Perseus study, in which VRD is being compared with the DARA VRD as part of the induction, consolidation, and maintenance. And in this trial, the primary endpoint is progression-free survival. And in terms of maintenance therapy, I previously told you that lenalidomide single-agent continuous therapy is today the standard of care. But fortunately, new options and new possibilities are being incorporated to the maintenance therapy in myeloma. Daratumumab single agent is being evaluated again in the Cassiopeia study, in the second part of this study. We don't have a solid data yet, but in this progression-free survival curve I showed you before, definitely we are observing the impact of daratumumab as monotherapy in this experimental arm receiving DVTD as part of the induction and consolidation. And in fact, a press release announced at the end of last year how DARA monotherapy was able to significantly improve the progression-free survival in comparison with observation. I realized that observation is not anymore the standard of care as maintenance, but it was the situation when the Cassiopeia study was designed. And definitely new combinations are coming, like daratumumab and lenalidomide, and we have a preliminary data coming again from the Griffin study. And when patients completed 1 year of maintenance with DARA plus lenalidomide, the complete response rate was almost 82% versus 60% for patients receiving lenalidomide only and maintenance. And important, this translated in approximately 63% of patients achieving MRD negativity. And you can see here how 40 and 30% of the patients were able to sustain the MRD as negative at 6 and at 12 months. And we will see, but definitely this information is going to be translated into excellent outcome for this specific subgroup of patients. And carfilzomib is also taking part of the maintenance in some experimental approaches, like in the Forte study. And when carfilzomib is added to lenalidomide as maintenance, the progression-free survival is also significantly longer. And again, you can see here how up to almost 50% of the patients were able to convert the MRD positive into negative. So I think that the good situation is that new options of maintenance are being incorporated to the management of this population. And in summary, and I think that this is my last slide, if we focus on the management of transplant-eligible newly diagnosed myeloma patients, don't forget the undetectable measurable residual disease and sustained over time as an important prognostic factor predicting progression-free survival and maybe also overall survival. And try to evaluate this undetectable measurable residual disease if the technology is available. How to manage them? I think that PIs in its plus anti-CD38 monoclonal antibodies and daratumumab is today the reality, are being incorporated as the new standard of care to be utilized as part of the induction and as consolidation after autologous stem cell transplantation. Transplant today remains a standard of care, and maintenance today continues being lenalidomide, but new options are coming. And definitely with all these news, with all these incorporations, I think that in the future we will be able maybe to offer the cure to some newly diagnosed myeloma patients. And I stop it here. Thank you very much for your attention.